the big worry I have is that we are moving into a kind of field where there is a kind of license of cruelty, particularly on social media, but different kinds of targets. So it's bigotry and cruelty are encouraged, but only if the target is right. So if you're someone who said the wrong thing, you establish yourself as a good person by abusing that person. And that seems to me to be very worrying indeed, because instead of saying we will have a kind of reflective debate about what's good and what's valuable, what's right and what's wrong, as human beings have been for millennia, we're going to say there's only one view, this is it, and if you disagree with it, you're a bad person.
You have found the Thinking Mind podcast.
Today I have with me Dr. Gwen Adshead. Dr. Gwen Adshead is a forensic psychiatrist and psychotherapist. She's worked at the highly secure psychiatric hospital Broadmoor for over 15 years, first as a consultant forensic psychiatrist and then as a consultant in forensic psychotherapy. She holds 2 master's degrees in medical law and ethics and mindfulness-based cognitive therapy. She's published a number of books and has over 100 papers to her name. In her role as both a forensic psychiatrist and psychotherapist, Dr. Adshead has tried to understand the psychological mechanisms that create the criminal minds of our society. She has worked as a member of a therapeutic team whose job it is to rehabilitate and deliver psychiatric care to those who are considered the most evil and dangerous, committing crimes such as serial homicide and paedophilia. Dr. Adshead has recently written a book called The Devil You Know, where she explores what is evil, who becomes evil, and how we may overcome evil. Dr. Gwen Adshead, thank you so much for joining me today. I note in your book, you always start by asking the individual where their story began. So I decided to ask you, where did your story begin, and how did you find yourself as a forensic psychotherapist today?
Well, I think it is a good question, and I came to develop. I came to learn that it was a good way to start. I think as part of the transition from a kind of traditional medical dialogue, because as physicians, we're trained to ask questions and get information, and that's just as it should be. And sometimes again, we're asking why questions, and what happened questions, and give me more information about that questions. But when you want to work in a more psychotherapeutic kind of way, regardless of your formal job title, if you want to have a more therapeutic kind of conversation, then you need to move into a different kind of linguistics. You need to use language in a different way. And I've found that the language of stories and storytelling and narrative is a better way to go, particularly when you meet people in a particular chapter in their lives. So, for example, in general adult psychiatry, we tend to meet people in a fairly traditional medical kind of way. So people come in with symptoms and signs, and we make diagnoses and we intervene and we try and relieve suffering and we try and treat the pathology. It's a fairly traditional kind of medical engagement, and most service users are up for that, and it works, and hopefully they get better and out they go. But there are other kinds of services, forensic is one, perinatal is another, where you meet someone in a very particular chapter of their life story. And I think that I've therefore found that the idea of saying, where does your story start, is often a much better way of inviting people in a way to tell the story of their lives, which takes you out of interrogatory mode. But again, encourages them to say, well, maybe it started when this happened. And then some people will say, well, really, I think it started when I was little and I was put into care, or whatever it happens to be. And then you, as the listener, as the other part of the dialogue, can actually take that up and run with it. And that's why I use that kind of language. And I guess my own story as a forensic psychiatrist starts. It actually starts when I was at medical school and I listened to Ian Kennedy's Reef lectures.
Okay.
And Ian Kennedy's Reith lectures, and they're worth listening to, because they are about the power that doctors have and some of the ethical dilemmas that arise in medicine because of the power that we as doctors can have. And when I listened to these as a medical student, a final year medical student, I was incensed. Who was this lawyer who didn't really understand what doctors go through? But then when I became a doctor and saw some of the ways that doctors get into ethical dilemmas, and the way that the law then arises and sometimes to solve this ethical dilemma, that's what drew me to do my first master's degree in medical law and ethics. And then once I'd done that, and I'd got a bit of experience then in reading legal cases and looking at how lawyers do judgments, that drew me to forensic psychiatry, because there obviously law and psychiatry were intertwined. And I really found that intellectually incredibly interesting. And then after that, really, I had a bit of time at the Institute of Psychiatry doing some research, but I think it was clear to me that my heart was really, I wanted to talk to patients, and it became clear to me that if I became a consultant psychiatrist in the regular way, everybody else would talk to the patients apart from me. The SHO would talk to the patients, the nurses would talk to the patients, the OT would talk to patients, and I, as a consultant sitting in the wardroom, I would be the only person who hadn't spoken to the patient. And I just thought, no, I don't want to work like that.
That makes sense. How do you go from forensic psychiatry to Broadmoor, though? Because is it fair to say that is one of the extremes of forensic psychiatry?
No, I wouldn't say so necessarily. I think forensic psychiatry is all about the relationship between mental disorders and violence, obviously.
Mm-hmm.
I mean, you mentioned crime in your intro, but actually, truthfully, forensic psychiatrists don't tend to get caught up with anything but violent crime. I mean, it's not completely true. Some forensic psychiatrists do work with people who steal or fraud, some kinds of legal cases you can get involved with. But generally speaking, most forensic psychiatrists get involved in those cases where we think that people's disturbed mental state has made a contribution to their violence risk. Now, this is really important because we know that the vast majority of people, there's no connection between mental disorder and violence. And the vast majority of people who have any kind of psychiatric diagnosis will never be violent to anybody. And yet, if you look at people who are violent, you do find slightly higher prevalence than you might expect of various kinds of mental disorders. So that's what forensic psychiatry is largely about. And I came to say my medical law and ethics degree was all about how you tease out responsibility. How do you tease out moral and legal responsibility? So that was why I was interested in that. But of course, the other side of forensic psychiatry is that we're caring for people who've committed acts of serious violence, often when they were mentally ill, or people who've committed acts of serious violence are serving a prison sentence, become mentally ill while in prison, and have to be transferred out for treatment. So, I mean, historically, I grew up professionally in a time when forensic services have greatly expanded. When I first started, medium secure services were just being developed. And that's partly why I ended up working at Broadmoor, because at that time Broadmoor was much bigger than it is now. There are about 600 patients, and there was a lot of psychiatric care and treatment, a lot of psychological therapy going on. Whereas now Broadmoor is very small. Broadmoor is only 200 patients. And the whole high secure estate is only about 1,000 beds. So, whereas the medium secure and low secure estate is vastly increased. So, but I mean, it was a practical issue really that what drew me to Broadmoor. There were two things really. One is that I lived not all that far away, but also there was a psychotherapy department. There was a medical psychotherapy department There had always been medical psychotherapists at Broadmoor, but a forensic psychotherapy department was being set up around the time that I started working there, initially as a regular forensic psychiatrist with a ward. And so it was a fantastic opportunity for me. I was very, very fortunate to be there around the beginning of this department being built up. These were happier days when there was more money in the system and much more commitment to medical psychotherapy than there is now.
Are you able to explain to our listeners what exactly psychotherapy is and how it differs from being a psychiatrist?
Oh, well, yes, I can, and I'd want to start straight away by saying that it isn't different from being a psychiatrist. I think that's a really important, if I may say so, a very important misunderstanding about being a medical psychotherapist. Does not mean in any way abandoning your psychiatric identity, and especially doesn't mean abandoning your medical identity. In fact, our identity as a physician is really important in being a psychotherapist. Mm-hmm. And the other thing about being a psychotherapist is that in a way you're being a psychiatrist who uses a particular set of tools, rather than actually becoming a different kind of professional. You're still a psychiatrist, but you're using a range of psychological tools, both in terms of understanding how minds work, but also understanding how minds change. Mm. So the long training is really in order to teach you something about how minds grow and develop. And then there's something about the kinds of interventions that you can use to help minds change. And medication is often an important adjuvant to that. But the psychiatric identity doesn't disappear in any way. And in fact, I think one of the slight, it's been a slight sort of professional cul-de-sac, really, in a way, that medical psychotherapy has developed into being a kind of specialty in its own right. In a way, there's an argument that says that everybody should become a medical psychotherapist. Every psychiatrist should also train as a psychotherapist, mm-hmm. at least to some degree. Mm-hmm. Because if you don't have any understanding of how minds grow and develop, and you don't have any understanding of the psychological mechanisms that lead to how minds change, you're going to be practicing psychiatry with one hand behind your back. Mm-hmm. Plus, it's going to be a bit boring, truthfully. And so I think that one of the big challenges for your generation over the next 10 years is to really be standing up for and fighting for having proper psychological training as part of both your core traineeship and also higher training, to make sure that you go into your consultant roles with a proper understanding of some of the psychological therapies and the techniques that help people change their minds for the better, even if you don't identify as a medical psychotherapist in the sense of having done a full 3-year training and had your own therapy, although that's not the worst thing in the world, I have to say. Having your own therapy is not a bad thing to do, because having the experience of being a patient mm-hmm. is really helpful.
Yeah. I have to say, I haven't began my psychotherapy training yet, but after reading your book, I definitely felt like I saw patients in a different way. And what I mean by that is initially, when I worked on an acute inpatient male ward, so I was dealing with men from the ages of 18 to 65 who were acutely unwell and were effectively sectioned in the public sense of the term. Initially, sometimes patients can come across as, on the surface, a nasty person, or they can come across as annoying, and they can inflict emotions in you that make you not like them. But as I read your book, it made me realise that really almost every perpetrator has been a victim themselves. And if you just try and dig a little deeper into why they are the way they are and what's happened to them, which is difficult in my experience, because when I have to go and see patients, I only have about an hour to try and work out whether they're safe to go home or safe to stay in hospital. But it really made me realise that the person that I had there had so much more of a story. And I think in your book, a message comes across that people are not born evil. and people become evil, and anyone has the possibility to become evil. Was that the main intention of your book, to get that message across? Was there anything else you wanted to specifically say?
Yeah, I know. I think you put it in a nutshell. I mean, I had been working on trying to write a book for a general audience because because of working as a forensic psychotherapist for many years, and together with my forensic psychotherapy colleagues, I had learned how people come to let themselves get into states of mind where they can be very cruel. And I also learned much more about what we might think of as the afflictive emotions, the painful emotions, the emotions of distress or anger or fear. And it is remarkable, if you think about it, it is remarkable that our psychiatric training is not very good in teaching us very much about emotions and where emotions come from. So I had learnt all this, and I'd been, writing about this in different ways. And I wanted to write something for a general audience, but my ideas about how to write this kept hitting the sort of buffers. I found I couldn't find a way to write it. And then I got together with a friend of mine who's a professional dramatist and a screenwriter and worked on television creating dramas for a long time. And she said, well, look, we could do this as a set of stories. And I can help you create narratives that are clinically accurate, but don't actually represent an actual individual, which wouldn't be possible otherwise. So, but the idea was very much an invitation to come and see the world I work in, come and see what I see, come and see the people that I meet, and go a bit deeper than you would. And I completely understand that when you're on call and you're coming to see somebody and you only have an hour, and you talk to them where you did for the exam, so you lots of rapid fire questions, get in the info, and it's, you don't have the time to reflect, and I get that. But I think it's absolutely essential that we as psychiatrists remind ourselves that those kind of encounters are indeed pretty superficial, and human minds are complex. And that is what I really felt that I wanted to get across to people. I wanted to share with people the extraordinary complexity and depth of the human mind. Human minds are not simple. And what you see on the surface is not all there is. And actually, that's a very traditional medical idea. We look for signs, but we know that the signs are not always what's underneath. And sometimes we have to go a bit deeper. So now, my working life is much improved by understanding that when somebody is angry, the chances are they're frightened or they're in pain.
Yeah.
And understanding that anger is a kind of defense against pain or fear enables me then to develop a kind of compassion for people that protects me professionally and reminds me that this is the person I'm talking to is the one with the problem. Not me. It's not a problem for me if they get angry with me, because it's not to do with me personally. It's to do with them being frightened or upset or miserable or frustrated. And my job as a psychiatrist is to get alongside that person and try and understand where they're coming from. So the book is really about how I try to learn how to do that. Lots of mistakes, lots of mess-ups, but how I tried to learn to develop a kind of capacity for what we've called radical empathy in the book, in which it's a kind of, in which you get up close to people, close enough to see what they're struggling with, but keeping that kind of a distance so you keep their danger and their potential for risk, which is in all of us, their potential for cruelty. You keep that in mind, but you also get close enough to see why people are struggling.
And some of the people you spoke to must have been very manipulative. How did you allow yourself to get close enough, but not get too close that you are emotionally vulnerable or at risk yourself?
Well, I think this is where having some therapy oneself is helpful. And I think the very word manipulative implies a kind of game or a dance almost. And one of the most important, one of the first steps you can take is not engaging in the game. So if the patient tells you something that's not true, or puts pressure on you to do something you don't want to do, then you can be, by increasing your self-reflective capacity and becoming aware that this is what's happening. This person's putting pressure on me right now to give them Zopiclone or whatever it happens to be. And I really don't want to do this. And I'm conscious of feeling angry. I'm conscious of feeling frustrated. I mean, that capacity for increased self-awareness and mindful attention, non-judgmental attention to present moment experience, actually helps to remind you that the patient is the one with the problem, not me. So if I'm feeling anxious or angry, that's something about what the patient is wanting or needing. And I don't have to identify with that feeling. Do you see what I mean? That I can understand it as a product of the transaction or the interaction that's happening between me and this person. That so I can find myself saying, why am I feeling so hot and bothered with this patient all of a sudden? Why am I really wanting to punch this patient on the nose? This is something about the transaction. This is about a human intersubjectivity, and intersubjectivity is a really important part of who we are as social animals. Social animals have a social mind and social emotions. We're built to transmit emotions and to read each other. So if you find yourself having a strong feeling about a patient, the chances are that's a kind of communication from them.
Yeah.
So, and it's our job to train ourselves to develop that capacity to just hold ourselves in not knowing and wonder what's going on with us. Not be too quick to judge. Not be too quick to. I mean, I myself would try never to use a word like manipulative about a patient. I would try and say, I wonder if this person is trying to coerce me or pressurize me into doing something for them that I don't want to do. And then then that just helps me to understand why I might feel annoyed and pissed off. But if I put a label on the patient, they're manipulative, then I'm ending up in a kind of judgment where that's going to close down dialogue rather than keeping it open. But of course, it's much easier if you have time, and in a way that this is what we need to be agitating for, is that we as psychiatrists get more time, to understand these things.
And you talk about that feeling as well, that something just wasn't quite right with the patient. I think it was one of the last cases of the book where you just knew that there was a facade, and underneath that there was a message that they were trying to portray. And it turned out this individual was watching child pornography, which was something that I wanted to discuss with you, because I know there are so many reasons why people murder someone else. For example, they may be psychotic, they may be absolutely raged in anger or jealousy, they may be under the influence of drugs or alcohol. But one thing that I came away from your book wondering is, what drives people to be a paedophile? And I wanted to ask you, what's your opinion on that?
Well, this is a really complicated area, really complicated area, because I mean, one of the things that you may or may not be surprised to learn is that not everybody who downloads child pornography would necessarily meet criteria for and certainly for DSM-4 paedophilia, in terms of a primary sexual interest in children. And the other thing is that there are, as far as we know, there are quite a lot of people who, of the people who might meet criteria for paedophilia, the vast majority of them probably never act on those urges or feelings. It's a great mistake to think that people always act on any sexual thought or feeling that they have in the moment. Most people don't. So I think the bigger question that we should be asking is that child pornography is a depiction of very vulnerable people suffering and being exploited and degraded at the hands of people who seem to be enjoying that degradation or shaming. So I think we have to ask ourselves why there is a business providing that material. And in a way, it's a question a bit like, why do we have such a huge business in illegal drugs? Why is that person a drug user? Well, it's possibly because there's a drugs trade. that supports them. And so the interesting thing about child pornography is that there is a huge business out there, and the internet has revolutionized this business. There are people who are making huge profits making these images for other people to download and buy with credit cards. It's a huge business. And those people who do it are often, in a way, using child pornography rather in the way that they use drugs, which is often to soothe themselves as a kind of stress reliever. Watching somebody else be abused or humiliated can be for some people, can be a kind of relief that somebody else is having a bad time and I'm not having a bad time. But there's a much bigger discussion to be had about the extent to which people who are vulnerable are seen as fair game for exploitation. And when that gets sexualized, then that leads to all kinds of violence, sexual violence, including of which child pornography is one kind.
It's a difficult discussion, really. I suppose you've seen so many things that may appear inhumane to others, and with time, I would imagine you become less shocked. What still shocks you today?
What still shocks me today? Well, I think the important thing to say is that the day that I'm not shocked, is the day I need to pack up and go home. And so I'm still shocked by plenty of the things that I hear, although I think so much shocked as just saddened. I think the sadness of it hits me, and maybe hits me more as I get older and my defenses are a bit more worn. And the tremendous sadness of so many lives ruined. So when this wretched man in Plymouth, who, if he'd not shot himself, would undoubtedly would be on his way to Belmarsh and then from Belmarsh to here. And that kind of story of intense unhappiness and rage and distress and conflict that then is enacted in a blaze of cruelty and destructiveness, in which so many lives are lost and wiped out in seconds, this seconds of hatred, but then his own life is lost as well. And the trouble is that when you kill, you can never, that's something that's irreparable. So most other kinds of offense, you might be able to make some kind of reparation. You might be able to build in some kind of hope for a better way of acting in the future. Even in the cases of sexual violence, and especially sort of general violence, fire setting, stalking is a bit hard to treat people who stalk. But nevertheless, these are kinds of aspects of human cruelty that you might be able to offer people some kind of hope for changing their minds about. But the trouble is that when you kill somebody, even if you help people recover their mental illness, saying that mental illness was part of it, or even develop a less risky state of mind for future life, that those deaths are permanent. The universe has been changed forever, and you can never go back to a time when that didn't happen, and that's really sad, really, really sad. So I think that's the thing that I find most hard, is just the sadness of lives, so many lives lost, particularly since so many perpetrators are young men. I think that's very sad as well.
You mentioned stalking is one of the hardest to treat. Why do you say that?
Well, partly because that's what the evidence says.
Fair enough.
And although, to be fair, I think not as many stalkers are offered treatment as we would like, but they're hard to treat, and they're hard to treat at least in part because the psychopathology underlying stalking is often quite delusional and psychotic, and the belief that the person being stalked is a possession to be achieved and owned, and that the stalker is right, that the stalker's take on the world is right and correct, and they're entitled. That belief helps to keep the stalker in a kind of stable state of mind. So there's not much in it for the stalker to give it up. And some of the milder kinds of stalking you may be able to turn around, I think, but it depends on the psychopathology. A lot of stalkers that we see in forensic services have very fixed beliefs about their victims, which certainly have delusional intensity. And it often reflects unresolved attachment problems from childhood, but people are often a bit resistant to treatment. So it's been very hard, it's very striking how hard it's been to offer treatment to people who stalk.
You mentioned that there's a difficulty getting therapy for those that are stalking, and in your book you speak a lot about the cuts the NHS have made to the mental health services in the past 10, 15 years. In an ideal world, I would love to know from you, what would a prison and a rehabilitation system in the UK, if you had all the money and all the control, what would our rehabilitation system look like? Would it look something more like in Norway, where people are able to get degrees, and what do you think?
I mean, there are two separate lines of thought here, I think, because clearly, as we've seen in this terrible Plymouth case, that young man was known to CAMHS. He was known to CAMHS. His conflicted relationship with his mother was very well known. And if you look at the stories of spree killings, if you look at the history of spree killings, they very, very frequently start with the shooting of a family member. And so one of the things that I would do is that we badly need to start CAMHS over. And we need to bring back all the family therapists who were cut. And we need to bring back psychotherapy training, and particularly training around attachment theory for everybody who works in CAMHS, including psychiatrists. So all CAMHS psychiatrists should be also psychotherapeutically trained. They should all be dual trainings, and we need, of course, 1,000 of them. So that's one thing. And we would hopefully pick up quite a lot of people much earlier on, before they get anywhere near acting out that gets them into criminal justice. And similarly, going back even further, I would build on the expansion of perinatal mental health and actually expand into parental mental health, so to help parents do better in terms of parenting. We know that the physical abuse of children is a potent predictor of violence in adulthood. In fact, physical abuse and neglect are the only potent predictors of violence in adulthood. So we need to do everything we can to stop physical abuse and neglect of children. So that means improving parental mental health services. So having done that, I would hope that we'd be making a bit of a dent in some of the violent offending that we would see, which is still a minority of offending. And then from a point of penal policy, I would be recommending, like many people have, I would be recommending against imprisonment for anything but high-risk violent offences. And then those in high-risk violent offences, you would be providing very intensive and extensive therapy programs, like they do in Holland, like they do in Norway, but you would reserve imprisonment only for people who committed serious acts of violence. And you would start from the premise that the job is to help these people change their minds. And the really political and social problem is encouraging communities to give up revenge as a way of being in the world. Revenge is a very natural and human emotion. We all understand that the wish to hurt back when we've been hurt, very natural, but we know that actually it's probably too expensive. We probably can't afford to vengeful feelings, and we all have to learn to manage our vengefulness in some other way, rather than building great big buildings and incarcerating people for long periods of time. It costs a lot of money to incarcerate people, and I'm not sure that we can afford it. the cheapest of prisons is about 20 grand. And the more expensive ones go up to 40 or 50, 45 grand. And we just can't afford it. High secure hospitals cost about 400 grand a year. So seriously, medium secure is about half that, low secure half that again. We really need to be doing better in terms of managing and trying to prevent people getting to that point if we possibly can.
And how much therapy are the inpatients or individuals getting when they're on your ward, and how many of them take it up and how many of them don't engage in therapy?
It varies a little bit with time. We're in forensic services, because we are trying to improve people's mental health and also decrease their risk to others. We have a bit more resource than many general adult services do, for example.
We don't have a therapist at the moment on my ward.
No, and also, most general adult services, you have to refer people to psychological therapies. They can wait for 6 months for an assessment, and then they wait for 18 months to be treated. The thing that's ironic about this is that this is exactly the situation that used to be with medical psychotherapy, and the medical psychotherapists were got rid of on the grounds that you had to wait a long time and it was very expensive and blah blah blah. Well, we have exactly the same situation now. It's just with psychologists, not with medical psychotherapists. So we have more resources, and we offer individual therapy to everybody. A lot of people can't take it up because they're too mentally unwell. And some people are resistant to start with, and we keep coming back and asking them. But we also offer group therapy to people, and that's really important. Group therapy is absolutely crucial for helping people develop a more pro-social state of mind, because individual therapy can't really do that. Individual therapy is very good for working on people's shame and experiences of trauma and fear, particularly in childhood, but it can't really help you develop a more pro-social state of mind. Whereas working in groups with other people like yourself is a very potent way of helping people, feel connected, which is really important. If you've done something horrible, to feel connected to a group of people is really helpful. But also you get to learn how to get used to other people's minds and take other people's minds seriously. And it's much easier and more effective to do that in group therapy than it is in individual. So of course you need both. You need group and individual therapy, and we do offer that to patients. And I would say that probably most of our patients have access, taking up some kind of therapy, and we're lucky enough to be able to offer a range of therapies. We offer cognitive therapy, of course, a very good place to start. We offer impulse control therapies like DBT for people who have problems with impulse control. And then we offer therapies like MBT, which work much more on people's relational minds and their ability to keep other people's minds in mind, if you like. And, a really good, what we really like best is when we've got somebody who's having some individual therapy, who's having some group therapy, who's doing some cognitive work around his mood or his psychosis. What we want is a menu of therapies. Just in the same way in spinal rehab, people get a lot of different therapies simultaneously. Yeah. After a forensic disaster, people often need a lot of therapies simultaneously. And often the role of the psychiatrist is, together with the psychologists and OTs and the nursing staff, is to work out a kind of timetable of therapy and evaluate how those things are going.
What proportion of people go on to live normal lives after Broadmoor?
Oh, what's a normal life?
Sorry, that was the wrong word to use.
No, I'm kidding.
Live independently.
Well, I think very few. But then I think that's the case for many people with serious mental illness. Mm-hmm. If you think about it in your general adult services, a lot of people are very handicapped they're very disabled by their chronic mental illness, and investment in recovery and rehabilitation is really important, and that's another area of mental health which needs much more bigging up in terms of supported housing, supported workplaces, There's a guy called Paul Lysaker in the States who's done really important work around therapies with people with psychosis to help build up their agency and their occupational achievements. Those kinds of things are really important. But I think the places like, in a way, it's helpful, I think, to think about Broadmoor Hospital as a bit like being the Royal Marsden. It's the Royal Marsden of mental health. So we preferentially admit here people with the most complex psychopathology, which has caused most harm and most damage. So you have to get your anticipated benefits, your treatment goals you have to adjust them accordingly. Your expectations have got to be right. Just as somebody who goes to the Marsden with very widespread cancer, we've got to get your expectations right. So, what we do is to try and help people get to a point where they could be managed in less security, and then hopefully they'll be able to move to lesser security again, and this is when we need much more placements. But in a way, your question begs a really interesting, much bigger one, which is big for everyone who works in mental health, is what does good mental health look like? And does it always involve living on your own in a little flat? Is that a sign of mental health? Because I would argue that it isn't. Actually, good mental health involves mature dependence on other people, being able to both rely on other people but also provide care for other people. So the idea that health is always about being independent is a rather odd idea, and culturally and historically rather peculiar to our time and our place. There are many cultures and times in human history where that idea of living in a solitary box on your own, and that means you're well, would be considered a very odd idea indeed.
It kind of speaks of the extremes of a Western school of thought taken to an extremis.
Well, and a very particular kind of Western thought, because I guess which West? Because I'm thinking, I mean, particularly, I guess, a sort of post-war kind of Western kind of take. Because what's interesting, I think, is that we've seen in social democracies where there's reasonably stable government, we've seen these dramatic falls in criminal violence in any culture that keeps that kind of data. But what we've also seen is this kind of increase in a type of individualism and talk about human rights, in which people are seen as somehow being sort of a much more atomistic kind of life, and everybody, and where the idea is that, you're going to get better, Jim, and you'll live in a little flat on your own, and and that'll be the sign that you're well. You don't need us anymore, as if needing other people was a bad thing. And I think that we need in the 21st century to be reappraising what social bonds mean and what communities mean. So there's different kinds of Wests, I think, and possibly different kinds of Easts too.
And I think what that made me think of is similar to the taboo on dependence and collectivism. I think we're also experiencing in our societies a certain taboo against aggression, and we have been for a long time. And what's interesting about forensic populations is, they're inherently fascinating to us because we spend most people spend most of their lives stuffing down their aggression as much as possible. And I think that's why television shows about crime like Breaking Bad or The Sopranos, all the true crime documentaries are so fascinating. In your professional development as a forensic psychotherapist, have you found that there's been a lot to do with becoming more familiar and integrating your own capacity for aggression?
Very much so, and I actually would make a very careful distinction, I think, between aggression and hostility, and anger. Because I think there's a kind of aggression which is a kind of what's the word I want? There's a kind of drive, the sort of drive to do things. That kind of drive is actually quite important, I think, in primate groups, and it may be quite important to be able to manage that. And there's a lot of social rules about managing that. It seems to me what you're really talking about is people's capacities for A, anger, but B, also the wish to hurt, and the kind of fury that comes when you're hurt and you want to hurt back. And I think you're right. I think that there's a kind of fear about being appropriately angry and how to get angry in sensible ways. Now, to be fair, Aristotle did describe that it is difficult to know how to get angry in the right way, at the right time, with the right person. And I think if Aristotle was struggling with it, we can anticipate that it's a reasonably complex human thing. But I think one of the things that I find frustrating is that it's partly because we see the human mind in rather simplistic terms. We don't see our minds as hugely complex organisms that they are. They are hugely complex with different levels of operating and different levels of conscious engagement or accessibility. And nobody seriously disputes that a lot of our psychological functioning is not conscious to us, although it may be perceived by other people. Now, our emotions are a case in point because many of our emotions have a social aspect to them. So, when you're angry, you're often angry with somebody or a situation. And sometimes the anger may be very important in communication to somebody else. But yet, I think there's a kind of pressure that mental health and goodness, a good person never feels angry, never gets cross, never is mean, never is horrible, never wants to do anything mean to anybody else. And that's what a good person is. And a healthy person never gets angry, never feels sad, never gets cruel. And I don't know where this idea has come from, because actually in human philosophical thought, understanding that painful, afflictive emotions and thoughts are part of the warp and weft of being human, and you have to get to grips with them, that has been a very well recognized line of thought in across all cultures and ages for thousands of years. And it seems to me we're going through a very odd fad at the moment, where if you say something, if you disagree with me, that means that you've offended me and you've caused me offense. You should never cause me offense. That means you're a bad person. And because you're a bad person, I'm allowed to attack you. I'm even allowed to threaten you with death if you say something that I find offensive. And when we gently say, it's illegal to threaten people with death, the person who's threatening death says, well, but they said something offensive to me. And you say, hello, hello. It's not possible to live a human life without dealing with offense and hatred and misery and rage and sadness. And the sooner we all grow up and recognize that, the better we should be. And actually we'll have a richer, happier life when we're able to look our devils in the face. And that's partly where the title of the book came from. It's better to know your devils than not. If you know the devil inside you, whether it's your rage or your pride or your avarice or your narcissism or your cruelty or your unresolved trauma or whatever it happens to be, better to know it and understand it and maybe have compassion for it. Maybe look after your sad, angry mind rather than pretending it's not there, or saying I'm a bad person for having such thoughts.
And to turn that around as well, I think a lot of people think that we should be happy all the time and it's natural to be happy all the time. But actually, Alex and I were discussing this earlier. We haven't evolved as humans to be happy all the time. We survive because we feel anxious, we feel fear, we feel anger. And it's not natural and it's not normal to feel happy all the time. And I also think we're living in a situation where on social media, happiness is portrayed as constant and it's so far from reality.
I agree with you. I think there's there's lots of books been written, haven't they, about the careful curating of people's narratives in social media. And I agree with you. There's a very limited and narrow vision that's offered, which is that I am always happy and successful. And it's almost as if, as you say, being unhappy and miserable is somehow associated with failure. But this is a kind of madness. I mean, to pick a word at random, this really is, because, and it's madness because it's not reality based. I mean, actually engaging in reality is a very important part of mental health. And a lot of mental disorder and distress comes from morbid attachment to unreal narratives or unreal ideas. And there's nothing, Frans de Waal is someone whose work I admire very much. He's a primatologist who's a very interesting and thoughtful man. And, it's quite clear that our non-human primate neighbors, with whom we share a lot of genetic material, they experience emotions which are part of their group life, and their emotions are communicative. And they don't throw people out when they're angry with each other. They have a stand-up fight, and that gets managed. Those relationships of conflict get managed, and there are also relationships of cooperation. So what we need is to be able to harness the complexity of our minds to be able to move from competition to cooperation as and when, and we can all get better at managing conflict. And one of the most important things we do is to recognize, as you say, that we all have these afflictive, painful emotions. And if we don't look after them properly, they'll come out in other ways. But the sooner, if we can get a kind of mastery of those and accept them as part of who we are, we may be able then to let them go and move on to the next thing. But as you say, expecting to be happy all the time is a kind of childlike state of mind. Although, having said that, I think quite a lot of children are more mature than that.
How do you manage all that anger and angst in a hospital environment like Broadmoor, where it's not a realistic environment? It's very far detached from living on the streets here. How do you manage that?
Well, I think it's very difficult, and it is one of the things that makes long-stay residential secure care tricky in recovery terms. And it's one of the reasons that length of stay is growing. Because, and it's not just in Broadmoor, it's really any long-stay residential secure care. It's actually quite hard to give people space to practice ordinary anger or ordinary distress. Obviously there's much more for us to do in helping people become normally or ordinarily angry. But I think one of the things that we can do is really, to go back to what you were saying, is to recognize that when people get angry, it's often because they're in pain or because they're in fear. And again, any of you who've ever had a pet will know, your dog only bites you when you step on its paw. That anger is often a response to something very painful or something very frightening. And if we can just try and see past the immediate threat display to trying to understand what's going on for this person underneath, and also trying to help people understand that if they hurt others with their anger, they will in a sense be hurting themselves, because they're damaging their capacity for social connection. And I'm sure you know that social isolation and social exclusion are potent contributors to mental disorder. So if we want to help people get better, we need to be helping them manage their social emotions better. And I would be arguing again for much more group therapy being available for people. And this isn't just because I'm trained as a group therapist, but it's because I passionately believe that actually if you put people in groups, you increase their capacity to learn from each other, and that increases their agency. And agency is really important for living a good life with other people, and for managing, the slings and arrows of outrageous fortune. Because we can't promise each other a life of perfect happiness, but we can promise a life to each other where we can support one another through difficult times. We can walk with people along the path.
In terms of social isolation, how many of your patients are in seclusion at Broadmoor, and how long typically do they spend in seclusion?
Very few. Very few are regular. I mean, it depends, of course, when you're talking about long-term seclusion. We have a capacity here to use long-term seclusion, perhaps more than some, although not dramatically different, I think, from medium security. But the fascinating thing, the really fascinating thing about places like Broadmoor is that you have to remember we preferentially admit the most disturbed people in the country. 200 of the most disturbed mentally disordered offenders in the country we preferentially admit here. And yet, our numbers of assaults by patients is very small. It's only a very small percentage of our patients who actually commit violence towards other patients or to staff. And it's the same people. It's something like 80% of the assaults are carried out by about 12 people. And those 12 people tend to live in seclusion. And what's fascinating about that is a mirror image of what happens in our society. That in 60 million people, of the 60 million people in England and Wales, about 80,000 are in, we just stay with the men for a moment, about 80,000 are in prison. But of that 80,000, only about a quarter, so let's say 20,000, are there for serious violence. And of that 20,000, only a tiny percentage, only a few hundred, will be in seclusion, will be in segregation, will be in high intensity prisons. It's a minority. And those men have all been admitted, all been detained in prison for violence, but only a minority will be violent. So violence, the thing about violence is it's an odd way for people to break the rules. It's a really odd way for people to break the rules. And when they do, it is usually a kind of communication to other people. And we should be taking violence really seriously because it's odd. And because most people are not violent. And so when they are violent, it's really important to take seriously.
Yeah, and I think you say in your book as well, a lot of people ask you, are you scared when you go to work? But actually you say you feel far safer on the wards than you do in the community, because actually these individuals aren't there to hurt you and you're there to help them, and it's far less likely that you will be attacked in that environment than actually out on the outside world where the risks are unknown.
Absolutely. I mean, violence risk, as you know, violence risk is based on a number of different factors, and of which mental illness is barely half of one. Paranoid mental states, mainly. Okay, well, so we contain our paranoid mental states by giving people medication. We don't have people who are intoxicated here because we don't have a problem with substance misuse. Very, very rarely, and nothing like the prison. So that's two factors gone. Yes, we have some young males, which are risk factors for violence, but most of our males are older. I mean, our average age is about 30, 35, something like that. They're older guys. But most of all, people generally, once they get here, they want to try and make use of what's available. They know that that our primary aim is to try and help them get better and, if possible, move on to less secure conditions. Whereas if you are sitting in a community mental health team with an open door, you have literally no idea what's coming through the door. Absolutely none. And there you could have someone where all the risk factors are lining up: young, male, intoxicated, paranoid, got some unresolved anger or distress that needs managing. And they come through the open door, whether it's a cafe or an MP surgery or whatever it happens to be. So, no, I mean, we invest a lot of time and effort managing risk here. So, no, I don't feel scared when I come to work. I'm much more likely to be scared. I'm much more scared on the idea of, when I think back when I was a junior doctor, having outpatient psychiatric clinics where literally anybody could walk in the door. They're much more risky situations.
Have you ever been attacked?
Oh yeah. I mean, you can't get through a psychiatric career, I think, without being assaulted once or twice. But I think all my experiences of assault have all been in general adult settings. One was in a PICU, one was in general adult ward. Again, patients who were acutely mentally disturbed, straight off being restrained. I mean, it's once in an MSU, patient got cross with me and gave me a bit of a push, barely an assault. He gave me a bit of a push, but nothing to write home about. But I mean, but even then, I'm not sure that I was frightened so much as annoyed.
When I've been attacked, I feel a little bit embarrassed that I've not assessed the risk as well as I should have.
Yeah, and I also feel bad that actually this is going to, partly it's going to generate a whole lot more paperwork, but also that the patient is now going to acquire a story of having attacked a doctor, which has a much more sticky quality than attacking a member of the nursing staff. As you know, the nursing staff get very annoyed about this, and rightly so. But it is unfortunately the case. So I think there's some. So I think I worry a little bit that this person's going to get labelled as being very dangerous, when actually often they're flailing around. They have no real intention to hurt you. They're just flailing around because they're terrified and resisting. Well, they're resisting being restrained, or they don't. It's not that they really want to cause you harm. So, but that's a different kind. And that really doesn't happen very often, I think, where you get people who really want to cause you harm.
Alex, do you have any further questions you want to ask?
One question, if that's okay, is two terms that I've been sort of quite fascinated with, and I have my own working definitions of them, are psychopathy and sociopathy. They're not terms technically in the diagnostic systems we use. We refer to the antisocial personality umbrella. But I want to ask you, do you think those are useful terms? And if so, what is the meaningful distinction between the two?
Well, if I start with the second question first, I've never found, I'm not sure I find the distinction particularly helpful. I've made, like most forensic psychiatrists, I've made quite a study of the work of Bob Hare, and I have no doubt that he is onto something. That there is a subgroup of people who are very violent, who have a very particular entitled and cruel mindset about other people. But if you go back to the original research, it's only a third of the violence perpetrators that he studied that actually got over the bar for his on his fledgling psychopathy checklist. Only a third. He was studying violent men in federal prisons in the States. Only a third of them got over his bar. And I think that's really important, because what it tells us, and I think it is true, most violence is not driven by psychopathy. And that's and the reason for this is quite clear, is that most violence, particularly fatal violence, is driven by the drug trade. If you look at the UN data on homicide, the UN Office for Drug Control presents data about homicide worldwide every few years, and they published their research 2019 quite recently. So, and the vast majority of homicides across the world are driven by the drugs trade. Which is why Honduras and Belize and Caracas have homicide rates off the scale. And are they driven by psychopathy? No, they're driven by armed capitalism. It's that's what it is. Then the next kind of homicide down is domestic violence. It's fatal relational violence. And again, very few of that violence will be driven by people who would score anything on the psychopathy checklist. The vast majority of perpetrators of fatal relational violence wouldn't get anywhere near scoring anything on the psychopathy checklist. And then you've got terrorism, terrorist-related homicide. Again, nobody's done the research, but I doubt very much those guys. Some of them might, some of them might score for psychopathy, but as you probably know, if you're organising something political, you probably don't want anybody who's not pro-social. They've got to be pro-social enough to work with you on your aims. You don't want people going rogue. And people who score highly on psychopathy tend to be very, very individualistic, highly narcissistic. There's a huge overlap between psychopathy and narcissism, pathological narcissism. So, and I think that, to answer your question, I believe that there is a group of people who have very high levels of pathological narcissism and degradation of the vulnerable. They're interested in denigrating and degrading the vulnerable. And I think mercifully the numbers of those people are very small. I think that we should only be worried about the ones who actually commit violent crimes and focus on them, which is where the research originally started. I think there's very little value in self-report psychopathy scales and studies of second-year undergraduates which show that 40% of them score something or other on a self-report psychopathy scale. But they don't even they wouldn't get anywhere near Hare's measure. But what's the point of finding out mild psychopathy if it doesn't result in any harm? And it comes really back to your original question, which is, what are we going to do with normal, horrible emotions, like wanting to be mean to someone? I know, I really hate that person. I'm bigoted against them. I don't like them. That person has something that I want. I'm mean. I mean, what's the value? Where's the value in medicalizing that? Where's the value in labeling that as psychopathy? Why not just say every human being has capacity for cruelty, vengefulness, meanness, pettiness, bigotry, every single person in the world. And we all have to get to grips with that. And calling it psychopathy I'm not sure how much it helps you really. I think it's only in those cases where it's accompanied by serious violence risk that it is worth taking very seriously then. And that's what the data says too, which helps.
Have you ever met anyone where you've delved into their childhood and you haven't found anything? You spoke about the bicycle lock in your book. Have you ever tried to delve into someone's history and not found any of those clicks, and you do feel maybe they are just, wouldn't use the word evil, but not a nice person, so to speak?
but you see, what's wrong with saying that someone is not in a nice, I suppose what I'm struggling with, it's the categorization, isn't it? Why don't we go for something, why don't we just assume that states of mind are dynamic and they change? Yeah, but that if you start from the position that anyone could get into a nasty, cruel state of mind, but that luckily perhaps very few of us will, or only in certain circumstances, then it seems to me that you're then able to have a kind of conversation which is a bit more interesting, which is about what are the circumstances. So, for example, if we look at Nazi Germany, where clearly something about the social milieu brought out and enabled a kind of cruel state of mind to continue and even to be part of social life, a kind of accepted kind of social life. And we've seen that replayed out in the former Yugoslavia, so it played out in Rwanda. It plays out quite regularly where a society decides to pick on a group of people and makes denigrating or hurting the vulnerable a kind of excitement or a kind of achievement. But I think we should start by assuming that we can all get into that state of mind, and history tells us we can. So what we're talking about when we come to forensic psychiatry, and perhaps psychiatry too, is that it's the same tune played on a piccolo, if you like. Whereas what happened in Nazi Germany or in Stalin's Russia is the tune played on the full orchestral version. But I don't know whether you've ever seen. There's a book about the Wannsee Conference in 1941, in which the final solution was planned out. Where basically Hitler's assistants planned out eradicating a bit of the citizenry right in the middle of a war, these men were devoting a lot of time and attention to eradicating some of the citizenry. Now, it was made into a very good film with Kenneth Branagh. But those men would not meet criteria for psychopathy. Not at all. Nor do I think those men had suffered childhood trauma. Nor do I think that they were, but they were men who perhaps had found themselves in a world that they contributed to, where fear and domination and cruelty were the accepted social language.
And perhaps, sorry to interrupt you.
No.
And perhaps in that society, in that time, there was something about locating all of the badness and the evil within one ethnic group.
Yeah.
I'm thinking about it from a kind of a psychoanalytic perspective.
Absolutely. And scapegoating, scapegoating is a defense mechanism in human groups. The one way to deal with these afflictive, if you don't deal with your afflictive emotions, it is easier perhaps to project them into somebody else and to locate them there and say, well, if we get rid of that, then we'll all be all right. And arguably, we've seen a little bit of that with Brexit, in which if we only get rid of our ties with Europe, everything will be fine. And we wait to see how that pans out. But from a psychodynamic point of view, there's a serious kind of scapegoating going on, I think. But my big worry, these are the kinds of worries you're allowed to have when you're in your 7th decade. The big worry I have is that we are moving into a kind of field where there is a kind of license of cruelty, particularly on social media, but different kinds of targets. So it's bigotry and cruelty are encouraged, but only if the target is right. So if you're someone who said the wrong thing, you establish yourself as a good person by abusing that person. And that seems to me to be very worrying indeed, because instead of saying we will have a kind of reflective debate about what's good and what's valuable, what's right and what's wrong, as human beings have been for millennia, we're going to say there's only one view. This is it, and if you disagree with it, you're a bad person, and I'm going to establish myself as a good person by abusing you and calling for your death. And I'm going to do nothing. I'm going to sit in my room and I'm not going to physically do anything. I'm just going to abuse you, and then I'm going to tell myself I'm a good person for abusing you, and that scares me. That scares me a lot, because I think the delusion that you're a good person by abusing other people, that's not going to end well.
Yeah. And what's disappointing about it is you're really seeing it across the political spectrum. And classically, you see a lot of things like this coming from the right. Usually on the political left, you would expect to see people who are more motivated by compassion. And yet nowadays, as you say, it's just a question of saying the wrong thing or not holding what's viewed to be the correct idea. And then having met that threshold, you have full license for cruelty or denigration of that person.
Yeah, I mean, I think we saw something really extraordinary happen. An artist at the Royal Academy who made a comment about something to do with the gender spectrum, and she had some lived experience of this, and her comment was seen in a very particular way, with a very particular lens, interpreted in a very rigid, monocular kind of way, and she was attacked. But a very small number of people then wrote to the Royal Academy and said, you must not stock her work. And they stopped stocking her work. She lost livelihood and there was hardly anybody. It wasn't even hundreds of people writing a petition. It was a few people writing into the Royal Academy saying, if you stock this person's work, we're going to ruin your business. And there's something about the kind of bullying that happens here, which worries me. But I think what you said, Alex, is really interesting about right and left, because I wonder whether in the 21st century we're going to have to rethink this, and this is an idea that actually was developed a little bit by C.S. Lewis, who was a philosopher and actually a Christian apologist, as it happens, but he was also mainly a philosopher and English literature specialist. So, but he talked about the importance, often within right-wing thought, you find an emphasis on individual and individual responsibility, but individual duty as well as individual responsibility. And the danger of that is that you lose sight of the communal obligations and the communal bonds. But similarly, on the left, there can be the emphasis on the community and the loss of sight of what the individual can do, and the importance of dissent, of individual differences in dissent. And so what he was arguing for was from being able to hold these complexities simultaneously in mind, and to trying not to collapse the wave function, if you like, into either the individual is dominant or the group is dominant, but actually we have these vastly expanded neocortices compared to our nearest primate neighbor. This is what they're for. That enhanced neocortical volume, that's what it's for, to do complex thought, to not do binary, bad or good, black or white, hateful, victim or perpetrator. We've got to take ourselves out of that kind of dualism into something that's much more complex and nuanced, and ultimately much richer and much more satisfying, but sometimes also uncomfortable, because we may sometimes feel that we have to step forward, and we can, in confusion, sometimes we have to tolerate some uncertainty. And that can be hard, particularly in the middle of a pandemic.
Yeah, it all seems to be about what I see happening over and over again in sort of public scenarios is falling into the trap of false dichotomies.
Yes.
And like you say, it's much more about embracing the uncertainty and the tension, and being aware that you need to use different sets of ideas at different times, different philosophies at different times. Like there's a reason there's a conservative way of thinking and a liberal way of thinking, is because sometimes you need a conservative solution and sometimes you need a liberal solution, sometimes somewhere in between. Yeah,
and you see, I think we see something of the same thing. Some of the tensions that there can be, which are completely unnecessary tensions between different schools of psychological therapy. There's no disputes about this. There are some kinds of problem for which cognitive behavioral therapy is absolutely the right intervention, and there are some other kinds of psychological problem for which it is not. And what's wrong with that? I mean, that's a standard medical model. There are, you won't do, you won't be offering just one kind of surgery in your local district general hospital. I'm so sorry, we don't do cardiac bypasses. We only do Whipple operations. It doesn't happen, but only in psychiatry have we had this very odd debate, although it's really a cover for money. It's a cover for money. But I think there's also, there's something for me that what you've just said, Alex, I really like, because I think it helps us as psychiatrists to know to use diagnoses in a more flexible way. That actually when we take a story from people, listen to their stories, and listen to the stories of their lives, where their symptoms fit into their identity. And we use diagnoses as an adjuvant kind of way of thinking. It's not the only way. We don't use a diagnosis to exclude or include. We say, these are the problems that this person is describing. There are some aspects that look a bit like this, and that's helpful because there's an evidence base for treating this. But we're going to keep this person and their story front and center, and that we're not going to let the diagnosis drive what we do. And this is what people want. People want person-centered psychiatry. They're not, the average service user, and I speak as somebody, who's used psychiatric services. I mean, I want to be looked after. I want to be listened to as a doctor listens to a patient. I want that traditional kind of therapeutic conversation. The idea that oh, I'm sorry, you haven't got a serious mental illness. I've talked to you for 20 minutes. I don't think you have serious mental illness. Not that I've got much training in it, and I'm afraid you can't access our service. So this seems to me to be absurd, absolutely absurd, because I can't squeeze you into a box, the diagnostic box, which, by the way, will be very crudely applied diagnostic box. I'm going to exclude you from services. And this seems to me to be extraordinary. We're turning away people in great distress because we've put some arbitrary, artificial box around the services. And the thing is that there's, I psychiatrically grew up in services which were not like this, so I find them unbearable, which is another reason perhaps why forensic psychiatry has been much easier in a way.
Yeah, it's hard to ignore.
Well, it is. There is that. I mean, as I said, there is that about forensic psychiatry, which is much more about who is this person and why are we meeting them now, and that is an invitation to conversation.
Do you have any advice for us as young psychiatrists for our future?
Yes. Well, take psychological pain seriously. I came to the concept of psychological pain a bit late in my professional life. I wished I'd understood that psychological pain is as real as physical pain, and that might be the main thing that people complain of. Never mind the symptoms and signs that are that we learn from membership. People might be in pain, and actually thinking about pain relief is important. But I would also take really good histories about the people's first 5 or 10 years of life, looking particularly at the attachments, the ruptures in attachments, and exposure to fear. Here is one thing that I wished I learned much earlier, and which I always tell people now. Don't ask people, were you abused as a child? Ask people, were you frightened of anybody when you were little? And that question will take you much, much further than any other question about childhood. Because obviously if the answer is no, that's great. And then you're off to the races in a way. But if they say yes, then you're who, when, how, what happened, who helped you, who didn't help you. And now you've got into something which is much more nuanced, something about identity, something about how people define themselves, not about abuse, yes or no.
Thank you so much for talking to us today. I've absolutely loved it. And just to say, The Devil You Know, the book is out now, and it's honestly amazing for those academic, but also anyone that has even the tiniest of interest in how the human brain works and why individuals may become evil, so to use the word. Thank you so much.
My pleasure. Thank you.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. If you find the podcast valuable, why not buy us a coffee to help keep us going? There's a link in the show notes. As ever, we love to hear from you and love to hear what you think. So drop us an email or get in touch on social media. Thank you so much.